Okay, let's go to the next question. Second question. Again, single answer. Okay, so we have our answers in irritability and anxiety. Everybody has voted for that. Let's see the correct answer. Yes, that is. So I think most of you have gone through the materials and everything, and there you have read on your own also quite a much. So okay, so vaping is the latest form of the uh, nicotine delivery system. It is also called e-cigarette, and in it the nicotine delivery is through various chemicals. They use various chemicals and flavors to deliver the nicotine system in the body, and it is obvious. It is no, it was marketed as not an alternative and a way to quit cigarettes, but many recent studies have shown that this has become a gateway drug. This was becoming a gateway drug for adolescents. Second, it was having an acute lung injury also. So it was becoming as similar, as harmful as cigarettes, if not more. Uh, when we will compare to any form of tobacco intake. Okay, so but this people have, and India it is banned, but is still available in black, but it is banned. And why is this more preferred for people is because it does not give off any smell. Okay, you can have two or three puffs while sitting in office, and nobody will get to know that you have had, because there is no smell to it, and it comes in different attractive flavors, which adds to its appeal. So, and quitting vaping is, we have not had so much of exposure to patients of vaping till now in the clinics also. But the recommendations for quitting vaping is similar to recommendations for quitting any form of other tobacco product. Okay, so okay, let's go to the next question. Okay, so we have our answers in, and okay, so majority has voted for B. B is the correct answer. So when you have had a patient in your tobacco cessation centers, and you have done tobacco cessation with them, now they are coming for follow up. Suppose if they have been abstinent for some time, and now you are doing a follow up, what will you ask? So will evaluate their cravings and triggers, the number of lapses. Okay, uh, and this will help you in further maintain giving them encouragement and motivation to maintain the abstinence. The What are the how they are handling cravings, how better they can handle, what are the triggers, what are the situations which is triggering the cravings or triggering the use. So you can identify those and discuss those in details in every follow up. And what caused, if there was lapse, what caused the lapse, and all that can be discussed, and motivation can be increased for maintaining the abstinence. Okay, let's go to the next question. Again, a single answer. Yes, so we have our answers in majority has voted for C. Yes, so that is the correct answer. You do not avoid discussion about tobacco use. Okay, you have to in the follow-up. Then encourage occasional tobacco use is wrong. You do not encourage occasional. You discourage, and if they have reduced it, even like harm reduction, so if harm reduction has been achieved, then next target is abstinence, complete abstinence also. If somebody is very resistant to not completely stop, then only harm reduction is the final goal. Okay. Then reducing physical activity, no, you have to ask them to have some physical activities. Uh, Even yoga exercise, we will talk about yoga, what kind of yogas, what are the evidence for yoga is there. Then identifying and managing high risk situations, so what situations, high risk situation they have faced, and how they can better able to manage them, that discussions need to be carried out is the best answer in the in this question. Okay, let's go to the next question. So we have our answers in now. Majority has answered increased anxiety and restlessness. Some has answered increased nicotine levels in the body. Okay, so during the withdrawal phase, it's not the nicotine level. Yes, nicotine does cause when you take nicotine during sleeping or just before sleep. Nicotine causes sleep disturbance and it is more involved in arousal. Okay, but during withdrawal, the anxiety and restlessness is one of the main factors that causes decrease sleep or difficulty in sleep. Okay, not others. Even when you are giving nicotine replacement therapies, sometimes they also cause disturbance. So nicotine patches, if that happens, we advise not to use it around the sleep time. And even if the patches are being used, we advise to remove the patches before going to bed. So yes, nicotine cause sleep disturbance, but during withdrawal, it does not. The anxiety and restlessness is the main factor that causes nicotine sleep disturbances. Okay. Okay, let's go to the next question. So we have our answers in. Yes, so maximum has voted for B. Yes, so first line is recommended behavioral counseling and support. Okay, that is the first line approach during pregnancy, because still we don't have strong enough evidence that nicotine is safe in pregnancy. So first line, it is not advised. Okay, but nicotine replacement therapy is anyways better than continuing to smoke or use any kind of tobacco product. So if a female is pregnant and is not able to stop with without medicine, or with even with behavioral counseling and support, they are not able to stop smoking, then nicotine is advised under close monitoring with like if we are giving for 1 month, then give for 2 months. So such kind of recommendations are there in many international guidelines. So nicotine replacement therapy is relatively considered safer during pregnancy, but it's still close monitoring is advised. Okay, and it is any time better than continuing to smoke or use any tobacco product is the main rule that you have to remember. Okay, let's go to the next question. Yes, so we have other answers in. Majority has voted for C. C is the correct answer. So others are not there. Others are not like research and studies have not shown any much difference in other aspects, but more intense craving and frequent use is more probable reason that the quitting tobacco makes is more challenging than alcohol. Okay, we will come to the last question now. It has multiple answers. Okay, so we have our answers in A and D have been voted most. That is the correct answer. So avoiding triggers and practicing deep breathing exercises, that is one of the 5 Ds that we recommend, like deep breathing, delay, drink water, discuss. Okay, and then using nicotine replacement therapy. So in that way, we are supplying nicotine to the brain. That is the addictive component of the tobacco products. So that will take care of that may take care of the craving. Isolating is not advised, rather it is advised that they go for to seek help and contact their uh, recovery network, and other things also, eating high sugar, no, so drinking water rather than that, and using alternatives is not at all advised. So yes, so that is it. Let's see the leaderboard. Yes, so Akarshan Agarwal with most highest correct answer and least time. Congratulations, Akarshan.
Thank you, sir.
Then Aishwarya Rao, Dr. Fins M. Philip. Sorry if I am pronouncing the name wrong. Then Nirav Patel and Kanav Bhardwaj, the top 5. All of them have got all the correct answers, but the timing difference is there, and Akarshan has the least time. So congratulations to everyone. Over to Tej Deepika. You can take ahead.
Thank you so much, sir. So some of the topics Abhishek sir has covered in Slido form. So other queries that we had received, we will take it through the presentation. Just allow me 2 minutes to share my presentation. Okay, so I'll quickly take you all through some of the queries that we had received. Tobacco use among special populations. So we had queries regarding, the treatment options for pregnant women and adolescents, relapse prevention strategies and other therapeutic interventions, pharmacotherapy, and alternative or complementary therapies for tobacco cessation. Okay. Now the first query was a repetitive one. We had a lot of queries regarding the pharmacological agents. Can I request Narsimha sir to take over this and guide us regarding the pharmacological agents?
Yeah. So thanks, Deepika, and good afternoon, everyone. I think in terms of the pharmacological agents, as you all know about the nicotine replacement therapy, apart from the nicotine replacement therapy, these two medicines are approved by FDA. One is bupropion, the other one is varenicline. So bupropion in general, we start with 150 mg once daily, and over a period of time, that around 5 days, 3 to 5 days, we increase it to 300 mg. So we advise people to set a quit date somewhere around 5 to 7 days. So that once the effect of medication starts happening, so then people were advised to set a quit date. So in terms of the effectiveness, bupropion has a good amount of effectiveness. It is almost similar to the nicotine replacement therapy. Also, bupropion is available and widely available across the country. So that is one more advantage. In terms of nortriptyline, again, the doses starts from 25 to 75. It is not approved by FDA, but there is some amount of evidence for use of nortriptyline as an anti-craving agent. And there are some side effects with nortriptyline. People start having excessive sedation. Nortriptyline also has some interactions with other medication. So generally, when all the other medicines fail, or when there is a comorbid depression or comorbid pain disorder, in such conditions, nortriptyline can be used. Again, there is also selegiline, which is also has been found to be effective in some studies, but it is not very commonly used. Another important medicine that might be coming up in India in next 1 or 2 months is cytisine, which is again approved. It is approved in UK and other countries, European countries, but it is not approved by FDA. But cytisine is something that will be coming into Indian market very soon. Again, cytisine is another drug which has been found to have effectiveness similar to varenicline. Varenicline is another drug. I don't know if is there another slide, Deepika, after
No,
this?
sir, I've kept it to this, sir.
Yeah. So there is another drug, varenicline, which is a bit costlier side. It acts on nicotinic receptors. It has highest level of evidence compared to all these three drugs. But the problem with that drug is it has been recently removed from the market, at least for last 2 years. It is only few brands are available. So the availability is an issue. There are some discussions going on, and that drug also might be available in another 3 to 6 months time. So in terms of the evidence, if I have to grade, varenicline has highest level of evidence, followed by bupropion, followed by rest of the other medicines. So this is about the pharmacological management. And in terms of the side effects, bupropion should be given in the morning time because it can cause sleep disturbances. It can reduce the appetite. Apart from that, in terms of the safety profile, if you are giving a plain preparation, there might be slightly an increased risk of seizures, but generally the available preparations are excel, so where the risk of seizures is almost nil. In terms of varenicline, there might be some mood changes. So these are some things about the medicines. Thank you.
Thank
If
you
there
so
are
much.
any questions, you can post in the chat. I will directly answer those questions in the chat itself. Thank you.
Thank you so much, sir. Proceeding further, So we had a query regarding therapeutic interventions other than motivational interviewing. So two things approved by the WHO is the usage of 5 A's and 5 R's. The technique of 5 A's, it involves components of ask, advise, assess, assist, and arrange. And 5 R's is for an individual who's not ready to quit. Basically, is unwilling to quit or has no motivation to quit. Then the following components will be useful. That is relevance, risk, rewards, roadblocks, and repetition. So these brief interventions are very useful apart from motivational interviewing. Yes, 5 R's does consist of certain components of motivational interviewing. These brief interventions, it was found that about considering 85% of the population visit a primary care clinician at least once a year, it is found to be very effective, and about 40% of the cases will make a quit attempt and have a quit rate of at least 2 to 3%. And also it is very cost effective, and it takes about it takes very few minutes to be able to employ these brief interventions. Okay, now we had many queries regarding relapse prevention strategies. So I'll quickly take you all through the specific interventions that's available and the global lifestyle self-control strategies that's available. The first being identifying and coping with high-risk situations. So we know what high-risk situations are. High-risk situations are those situations in which the client is most vulnerable or likely to use the substance. So in collaboration with your client, try and identify and address high-risk situations. When I say in collaboration, what you can do is you try to explore the past, circumstances or triggers which has led to relapse. And also, it is also very important to understand the coping skills of your client. And if you feel that, the coping skills of your client is inadequate, so it's very important to, impart general coping skills to your client, like stress management, lifestyle modification, which I'll be talking, as we go forward. Enhancing self-efficacy. So we know self-efficacy is basically the ability to believe in one's capability of bringing about a change in oneself. So when I say, enhancing self-efficacy, there are certain things as a clinician we can do. First is trying to break down the behavioral task into smaller tasks, so that when the client actually achieves these subtasks or smaller tasks, it will actually enhance his confidence level and thereby increase his self-efficacy. And also try as a clinician to give more of positive constructive feedback, especially about tasks not related to substance use. For example, him coming for sessions or him probably doing the homework tasks that you assign to him. These are all tasks that are not related directly to the substance use. So try giving them positive constructive feedback, which in turn will increase their self-efficacy. Next is eliminating myths and placebo effects. So by this, what I mean is that try counteracting the myths or the placebo effects the client has with regard to uses of the substance. So what you can do is, with regard to eliminating myths, try asking your client to consider the immediate and delayed consequences of using their substances. That is one of the effective strategy that you can use. The other thing is lapse management. Can we have anyone in the participant who can tell us, if you have a client who comes to you with a relapse, what are the things that you can do? Can anyone unmute and tell us? Anyone, generally, if you have a client who has just had, yes, ma'am.
Good afternoon, ma'am.
Good afternoon, sir.
I'm Dr. Vivekanandan, second year postgraduate.
Good afternoon, sir. Go ahead.
We can guide the client to have a small puff or a half of the cigarette instead of a complete cigarette, to 2 to 3 puffs instead of a complete cigarette smoking.
Okay. So thank you so much, sir. So in lapse management, generally what we do is we try to get into a contract with the client as much as possible to limit their use. you tell the client that if the moment there is an instance of lapse, to try and reach out to the case manager immediately, and try understanding what has led to the lapse. Try understanding more about the triggers and the circumstances which has led to lapse. And last thing that you can do is you can probably give him a brief, simple written instruction as to what he can do whenever there is a whenever there is a lapse. So these are all certain things that is a part of lapse management. Another thing is cognitive restructuring. Anyone would like to share their insight about this technique? Okay, see, the general belief is that a person who actually goes through relapse, it is not like he has just had a thought about using and he immediately uses the substance. There's a lot of thoughts that he has, red flag thoughts or maladaptive thoughts that he has before he actually uses the substance. So as a clinician, what we need to do is psychoeducate the client about these red flag thoughts and how he needs to challenge these red flag thoughts. So, for example, if you have a client who tells you that, I had this thought that, for example, if this day is too terrible, I think I need to have a smoke to relax myself. So you can probably tell your client to challenge these maladaptive thoughts by making counter statements or positive statements like, what is the evidence that smoking is going to relax me? And even if it does relax me, it is going to be up till only for a short period of time. But what after that? What about the effect it's having on me in the longer run? So what you do in cognitive restructuring is you try to tell your client to challenge these maladaptive thoughts, try and convert these maladaptive or negative thoughts into opposite of it, which is more positive and more constructive. So it's about cognitive restructuring. Encourage the client to have more realistic self expectations, and understand from where these thoughts are stemming from. Now coming to global lifestyle self-control strategies, the first is balanced lifestyle and positive addiction. Next is stimulus control techniques. In stimulus control techniques, the most important thing is to help the client understand the importance of reducing the cues of substances. For example, you can tell your client that he has to reduce cues such as, probably, stickers related to alcohol or tobacco, or probably, removing, if it is a tobacco addiction, probably removing lighters or ashtrays, or if it is alcohol, ensuring that there is no liquor bottles available, easily available. So these are all stimulus control techniques. In urge management, another technique is the cue exposure technique. So what we do is the trigger is combined with a coping mechanism. For example, if the trigger for the client is going for a weekend party in which all of his friends are going to smoke, so try and tell your client that he has to, come up with a coping strategy for it. For example, if he is for sure that he is going to drink or smoke in the party, it is better that he associates it with a coping strategy. For example, weekend parties can be associated with spending more time at home. So he has to come up with a coping strategy for the cue. Next is urge management technique. In urge management technique, what we tell the client is, each time you have a desire to drink, it is not, it is not a signal for you that it is actually a desire for you to drink. It is actually, it's actually signaling an emotional or a physiological response. So what you do is you help the client label this as more of an emotional and physiological response rather than it being a desire to use the substance immediately. And next being relapse roadmaps. In simple words, relapse roadmaps are about having an analysis of all the high-risk situation, and in collaboration with the client, try and understand what are the available options before the client in order to avoid these situations. For example, if it is weekend parties or office parties in which he is most likely to feel vulnerable, so try and see what are the other ways in which the client can tackle this situation or avoid these situations. Okay, so I want to quickly at this point of time tell all of y'all that we have an upcoming primer on relapse prevention. Towards the end of the session, we'll probably be sharing the link as well. So it's upcoming. Presently, the work is going on. We will keep you all updated about the primer on relapse prevention. It's an opportunity for all of you to gain more information and more insights about relapse prevention. Okay, now we had another query regarding adolescent tobacco use. So before I start about the treatment options, I would like to quickly outline the factors that causes adolescent to use tobacco or nicotine. So mainly it is about the mental health status of the individual, the beliefs the adolescent holds about smoking, how his people around him perceive smoking, especially his schoolmates or his peer circle, and if he's using other substances. Other factors such as emotional problems, including depression or any recent negative event, can also definitely increase the risk of smoking. One more factor to consider here is smoking among peers and within social groups. Now, with regard to treatment options that's available for adolescents, counseling interventions should be provided to address tobacco use in adolescents, and it is found to be more effective than the usual care, like probably providing brief advice or giving them self-help brochures or treatment. Uh, uh, I'll probably ask Narasimha sir or Abhishek sir to talk about what are the available options for an adolescent.
Yeah, hi. So yeah, adolescents similar kind of nicotine replacement therapies have been proven to be good for adolescents also. Um, so that can be tried, and behavioral therapies are there. I'm not sure about the varenicline for adolescents. I think that Narasimha sir will be better able to tell about that. But NRTs have been approved, and they have been tried in adolescents safely, no, without any issues. More or less, you have to focus on the underlying root cause that is leading to the problem. The comorbid conditions like any ODD or conduct disorder or anxiety, depression, emotional problems, any trauma that they have suffered, though that is to be focused more compared to only tobacco, right? Like in adults, even if you focus only on tobacco use, you may get a little bit more success than only adolescents compared to adolescents. So in adolescent, you have to focus on the underlying cause. Otherwise, they do not even connect with you if only for keep focusing on tobacco, because for most of them it's considered like their um, yeah, peer group is doing that and it is cool to do that. So, and you are an adult, you don't understand. So all that factors you have to like overcome before doing any kind of intervention in that. I think Narasimha sir, over to you, sir, for the other pharmacological agents.
Yeah. Thanks, Abhishek. I think what Abhishek has told is correct. Only the nicotine replacement therapy is something that is approved at least till the age of 18 years. But less than 18 years, the approval for use of varenicline is not there. But in terms of bupropion, there has been studies which have shown that bupropion can be used in this age also, specifically in adolescents. The main challenge with adolescents is most of the adolescents do not come to any treatment center for the treatment of their tobacco related problems. So we might encounter adolescents particularly coming with other problems like what Abhishek was telling, that they come with emotional problems, or we are encountering them at correctional facilities, or they have come with other health conditions, physical health conditions like dental caries or any other asthma getting exacerbated with because of use of tobacco. So in these contexts, what the evidence suggests is these brief interventions which are done by the other specialists. So for example, if you're a general primary care physician, when you identified that is the person's his or her asthma is getting exaggerated by the tobacco use, so doing brief intervention has been found to be extremely helpful So you spend 5 minutes of time and explain how asthma is related to tobacco use and how these exacerbations. Second thing is when you are seeing adolescent population where parents are using tobacco, in that context also, because of the passive smoking, the children health problems gets exacerbated. So in that context also, doing brief interventions has been found to be helpful. Otherwise, most of the people, when we see adolescent, it is predominantly at the level of when you have this when they have other medical issues or psychological issues. The other population is school and college population where you are doing preventive aspects. So especially in the preventive aspect, when you involve adolescents in these preventive activities, that's where some evidence is there. By doing some of the activities like tobacco, no tobacco day, there is some evidence. But in terms of uh, treatment settings, there is a lot of evidence for brief interventions. So, because there are a lot of primary care physicians and other healthcare providers, whenever there is an opportunity, when you see adolescents, please do brief interventions. So that has a lot of evidence. Thank you.
Thank you, sir. Okay, next is regarding tobacco cessation for pregnant women. Abhishek sir had already answered. Clinical trial evidence has found that counseling, when it is delivered in the most sufficient intensity, is very effective in increasing the cessation rates among pregnant women. And also, when there is use of nicotine replacement therapy among pregnant women, it is very important that it is monitored on a periodic basis. Okay, the last query that we had was regarding effectiveness of yoga on tobacco cessation. So one of the studies indicated that when there was a comparison made between Iyengar yoga versus general wellness classes, it was found that having yoga and the CBT intervention, it found significant benefits in achieving abstinence at 6-month follow-up compared to CBT plus general wellness classes. Here, one thing we need to note is that we have considered only studies with rigorous methodology. Considering there is very insufficient evidence, it is very important that we all of us have a comprehensive approach to support tobacco cessation, which basically includes both behavioral support and or pharmacotherapy. Thank you so much. We've covered most of the queries so far. So we can proceed with the functioning of Quitline. Can I ask Mahashweta to take over?
Sure. Am I audible? Just a quick question. Okay. Let me just share my screen. Okay. So I'll be giving a brief about the functioning system of our National Tobacco Quitline Services. So this is the toll-free number. I hope you all have seen this number in the tobacco packets or anywhere in these tobacco products. So it was started on 1st September 2018, and on the same day, Ministry of Healthcare and Government of India established 3 more regional TQL center. These are in Delhi, Guwahati, Mumbai, and one in Bangalore. So this is the functionality, like the first description, and there will be counseling available 24 hours a day throughout the year, except for Mondays. Mondays are the week offs. So quickly going to the functionality. So how does it goes? So first there will be call, like you can call on this toll-free number, that is 1-800-11-2356. And once the call's been registered, the counselor will be picking it up, taking a brief assessment, tobacco use, quick history, all the demographic details. And it will the counselor will establish a collaborative agenda to address specific concerns of the participant, and also uses assessment information to help participant build a quick plan. And in the next contact time, within 2 days of planned a quick date. So we have a pre-quick date and a quick date, and followed by that, we have follow-up calls and maintenance calls, right? So in just to go in details, so this is how it looks. So we have 6 languages over there: Kannada, Tamil, Telugu, Malayalam, Hindi, and English. So based on the comfort level of the client, they will be choosing that particular language, and that call will be forwarded to the particular language counselor. So once it is greeted by the counselor about the call, they will introduce and give a little bit of introduction. And after that, they will start the counseling with certain information, which includes demographic details, tobacco use related to information, smoke and smokeless form, detail of physical and mental health, family history of tobacco use. About the counselors explains caller in their language understandable to the caller. As part of the TQL working protocol, counselor will do a minimum of 5 outbound calls for telephonic follow-up of the caller. So there will be a 5 to 6 outbound calls that we will be calling them to take the follow-ups, like what they are doing or how the counseling is going so far. So once the data is collected, entire data, we take a feedback will be given to the caller about the level of severity of tobacco use, its impact on him or her. So after that, there will be strategies that will be given, the plan part. So where it will be explained the caller based on the WHO manual, and the end caller will be motivated to set a quit date on which he will quit. Now in the quit date again, we have 3 extendable date. Like if they have chosen 30th September will be the quit date, they can again extend it to another further date according to their conveniences. So the tips contains with the start technique, craving and withdrawal management, 5 A's, 4 D's techniques, tobacco dairy, understanding the 4 P's, relapse prevention, home remedies, and also some of the ideas how they can do some little lifestyle changes as well. So after they have made a quit date, there will be a 4 outbound calls will be made as per pre-quit date, like before they even start with their quit date. So there will be 4 outbound calls will be going to them. So after that, on quit date, 1 week follow-up call. After that, 1 month, 2 months, 6 months, and 1 year. So after 1 year, followed by their quit date, we'll be giving them follow-up calls or supportive calls in case if they need anything, like how their entire day is going, any problems they are facing, any issues or any particular thing that they want to address, or in general time how they are coping with no tobacco or tobacco products. So the counselor suggests other techniques if they face any issues and motivates the client to quit the set quit date. The counselor extend the quit date if the caller couldn't adhere to the quitting. So after 1 year again, we'll be doing follow-ups or supportive calls. After that, after we are satisfied that they are not using the products anymore, we will terminate for that case. So this is the entire way that we function in NTQL. And also along with the telephonic counseling, we give them printed materials, quitline guidelines or other materials which will be supportive for them to quit, to give them the motivation, messages, services to increase the quit attempts, a gentle reminder that you are supposed to do this, the plans or simple words for them to just to give them a push, referral service calls. It can be done by like adolescents calling or anybody referring to for somebody else way of taking tobacco products. Also online offline awareness events. Recently we came up with another tobacco quitline live chat as well. So here if people are not very much comfortable calling up and talking in a first space to the counselor, they can give their problem details, the issues, and some of information. So from there onward, we build up with conversation what is their problem. We try to get the information, and then within a convenient time or where the client is feeling comfortable, we'll give them a call based on their details that they have provided. So apart from that, we do online and offline awareness event campaigns, and also training counselor, STCC, and other professionals about tobacco cessation counseling. So training programs. Also, in regard to that, we are upcoming. There is a workshop on 28th of September where we'll be giving workshop on like how to initiate a tobacco cessation center, the service, how can you initiate from your part. So there will be detailed workshop on that 1-day program, and we are still working on that, and we'll be posting the agenda and the whole thing to you all. So this is about NTQL and its functioning. So thank you all, and again get back to you, Techika, over to you.
Thank you so much, Mahashweta. So we'll proceed with the primer on tobacco session. I would like to ask Akshita to take over.
Thank you so much, ma'am. I hope I'm audible. Okay. Okay, so just give me a moment. I'll share my screen with you all. Hi, so good afternoon, everyone, and I'll be giving the basic introduction of the primer on tobacco cessation. So let's talk about what this is. So this is basically a self-learning module on tobacco cessation, and it aligns with the weekend enhanced mission of democratizing addiction and mental health knowledge. So this module is primarily for healthcare professionals and counselors. It has 3 lessons, which constitutes of several topics, which offer evidence-based strategies and interactive learning, and it is there for easy access, so you can approach it and you can go through it. So the question comes up, how do you enroll into it? So once you go to the website, you will find on the upper right corner the login pop-up, and from there, once you click on the login, you will see a pop-up as register. When you on register, then you make an account. Keep your password and your ID with yourself, because that will be required in the future. And when you enter your name, remember to enter it correctly, as the same name will be used for your certification as well. So then comes up, you click on the take course, and then you are directed to the fee payment. So then while doing the payment, remember to use the correct login, correct email and mobile number. And then once the payment has been done, remember to share the receipt on the given email ID, which is weekend@weekendenhance.in. So once you have shared the receipt, you will be able to access the module, and then it is done. So your enrollment will be done after this process. So then comes up, why should you enroll into this particular primer? So as we have already mentioned, that the objective of this module is that it helps you in recognizing what are the problem of the tobacco use disorders, and outline the principles of the tobacco cessation. So after completing the module, you should be able to recognize the public health importance of tobacco use and associated policy, and summarize the screening and brief intervention for the tobacco cessation. And for whom? So this can be for anyone who wants to learn more about the tobacco problem, and specifically it will be very helpful for the healthcare providers who work in the field of mental health and tobacco control, TB elimination, and non-communicable disease control programs as well. So this primer will have 3 lessons, and they will have 3 to 4 topics each. The topic will have a written description, didactic presentation, a recording video, and short reading materials. So each module will also have a quiz, and one needs to complete all the topics given in particular lessons. And in quiz, you have to attend the, at least you are required to score a minimum of 80% to pass the particular quiz. You will be getting 2 attempts to complete the quiz. And remember to, while attending the quiz, you are allowed to use only one digital platform. That is, at one point, you can either log in through your phone or laptop. It won't allow the concurrent login from other devices. And once you got the access of the module, it will be there with you for the 30 days. So you are advised to complete all the topics, all the lessons, and the quizzes within this 30 days. And the complete primer will take approx 5 to 6 hours. So if you give 2 hours per week also, it will be good to go. So then coming to the certificate of completion. So as we have already mentioned that there are 3 lessons, and then they have particular topics. So you need to complete all the topics and then all the quiz with the minimum score of at least 80%. Then once all these criteria are filled, you will find your certificate of completion on the dashboard. And then the fee contribution, so the fees that you have deposited, that goes into maintaining of the edutech platform, and it helps us to run a secure and efficient cloud-based system. So yeah, that is all for the primer. Thank you so much. Over to you, to Tilka ma'am.
Thank you so much, Akshita. So, Akshita has just outlined about the primer on tobacco session. And if any of y'all are interested in primer on tobacco session, do log in and complete the course, complete the primer on tobacco session. In the month of October, tentatively, we have the comprehensive tobacco session certificate course 8.0 that's coming up. All the participants who finish the primer will get early access to the course. So I suggest all of you all to do the primer and get the opportunity. Just allow me a minute. I will just give a brief overview about the upcoming course. So, like I told you all, there is the upcoming course that is tentatively coming up in the month of October. So, what are the objectives for this course? It is primarily for identification, screening for tobacco use disorder, assessing the severity by using an objective scale, practicing evidence-based counseling and psychosocial intervention to prevent relapse. How do you go about prescribing the over-the-counter nicotine replacement therapy and basic knowledge about pharmacotherapy? Decision making regarding what can be managed and what needs to be referred. So these are the objectives for the course that is coming up tentatively in the month of October. So the focus is on all teach, all learn model. So what is the core instructional design for this course? The essence of the course is the case discussion. So you are required to present one detailed tobacco use disorder case summary. Then the session will have interactive Slido quizzes and assignments which happens on the eLearn portal. And you will also be given the provision of self-paced learning materials. Okay, so it's an accredited course. There are few aspects that you need to keep in mind. First being attendance. So you're required to have at least 75% attendance. That is, you're required to attend at least 9 out of 12 tele-echo sessions with more than 60 minutes of video presence. Like I just mentioned, submission of one case summary in the live tele-echo session. You're required to have at least more than 75% score in each of the 3 assignments. Then there will be evaluation of the number of patients seen. So you are required to fill up monthly record form every month and completion of pre and post-test surveys. Okay, now what are the core competencies that you will achieve if you get accredited from the course? You will be in a position to access for tobacco use among your patient, clients, or people around you. You will be in a position to estimate the severity of tobacco use by using structured scales. You can employ brief intervention as well as you will be in a position to employ extended intervention based on motivation enhancement skills, and you will be able to plan and implement relapse prevention strategies. So, if there is anyone among the participants who've still not got a chance to access the primer on tobacco session, we encourage all of you to access the primer on tobacco session because the faster you finish the primer, you will get an early access to the course, which is going to happen in the month of October. The enrollment form is likely to be out in the month of September. We will keep all of you posted. Thank you so much. If we have just 2 minutes, if there's any queries, we'll take it up before we wrap up today's session. We also have primer on relapse prevention that is coming up. We will keep all of you all posted about it. Presently, work is going on. We will keep all of you posted regarding the primer as well.
Yeah. Hello, ma'am.
Yes, ma'am. Go ahead.
Yeah, ma'am. I'm Dr. Alka. I just, want to give one suggestion. As you people are organizing wonderful, programs on tobacco cessation and alcohol substance also, we need a program on mobile de-addiction also. If you can organize such programs, then it will be really great, as all of your, programs which you people offered, they are enriched with knowledge and research. If you can really, think about all this. Yeah.
Thank you so much, ma'am. We will try to incorporate your suggestion, ma'am. And we have quickly running through the queries on the chat. Do we have further workshops and webinars? As Mahashweta had outlined, we have an on-site one-day training that is coming up in the month of September tentatively. Mahashweta, would you like to quickly outline about that on-site training?
Yeah, sure. So the tentative date is 28th of September. So there we are planning to give you a detailed audition of outline of how you can start with tobacco cessation services. So it will be given with the things that we generally like, how to set up a particular place with whatever the things that you are going to need, the practices, the assistance of from the counseling till taking it in OPD, taking patients, medicines, and everything. So we'll try to give a detailed outline of the entire program, of the entire service of tobacco cessation. So that is our plan for now. So that's how we have trying to organize that. Yeah.
Thank you so much, Mahashweta. So regarding the course that's coming up in October, Comprehensive Tobacco Session Certificate course, so far presently the back-end work is going on. So we are not yet sure about which day the session will happen, but this live teleco sessions will happen once in a week. The enrollment form will be out by September, so we encourage all of you to finish the primer by then. When you have the enrollment form ready in the month of September, all of y'all will be given complete information about how the sessions will happen, the day, the accreditation criteria, and all of it. So how to register for the workshop? Presently, like Mahashweta has told us, presently the back-end work is going on. We are working on it. We will keep all of you posted. Yeah, if any last queries before we wrap up?
Ma'am, I'm Rajni Yadav. Can I ask you for recording for today's session?
Ma'am,
Can you send me how we can have the 2 days recording? 2 days session recording.
okay, ma'am, I'm not too sure about the recording. What I can do is I can probably share the PPTs that we have used in today's presentation.
Okay, ma'am. Thank you, ma'am.
Okay, yeah, thank you so much, ma'am. Hope that will be helpful.
Oh.
Okay, if there are no queries, we can wrap up today's session. I take this opportunity to thank all of you who have made time, taken time of your busy schedule to join today's Q&A session. We will keep you all posted about the on-site one-day training that is likely to happen in September, as well as the certificate course that's going to happen in the month of October, and also the primer on relapse prevention that is going to come up shortly. Thank you so much, everyone, for joining. I also thank my hub team for joining today's session. Thank you so much.
Thank you.
Thank you, everyone. Have a pleasant evening. You can log out now. Thank you so much.
Recording